have an endometriosis of the nerves. So we were really lacking this field. And when this paper of yours had come, it reminded me of somebody landing on the moon, where they said it's a small step for man, but it's a big step for mankind. And exactly, I feel your paper has really put a very good information for all of us to upgrade ourselves. And Suyesh, I can see him on the screen as we are doing neuropelviology with the eyes on. I think now pelvic neurosonography is one more thing we have to add to our feathers and to our armamentarium. And we really eagerly look forward to Gabor and listen to him. And then we will have a lot of question and answers for him. So I request Dr. Gabor to deliver his speech. Thank you.
Thank you very much for the kind invitation and for the very kind introduction. I'm very honored to present today my lecture, and I think it's really something, a field which is in developing, because this is something, a step forward. Deep endometriosis made us to be aware that we do not perform only gynecologic scan, ultrasonography examination, but also pelvic ultrasound. So we are looking for urinary bladder, we are looking for the ureter, we have a lot of signs for rectal endometriosis. But as you mentioned, the parametrium, the pelvic side wall, and also the nerves can be affected by the deep endometriosis. So I think it's really important to look for that during the scan. I want to start with my sharing. The question.
Gaber, your voice is a little low. Is it possible to increase the voice? Yeah.
Can you hear me? Is it better now?
Not significantly. We can hear you definitely, but it's not loud. I mean, it would be better if it's possible.
Okay, let's look for the. So this is my maximum voice. Can you hear me?
No worry. Yes, we can. Yeah.
Perfect.
Good enough. Yeah.
So I just want to start to share my screen. And the question is, if you can see how my slides are going forward. Can you see the movement? Is it moving?
If it's a video, it's not playing. No.
So you can see only my first slide.
Yes.
Oh,
can you make it full screen?
Yeah, it's on full screen. Just a second. So I made on full screen, but now I cannot see the. Do you know the knobs? How can I change back to the Zoom if I'm on full screen? Okay. I think I got it.
For full screen, you have to press the slideshow, basically. Slideshow button on the top.
Just a second, I made it. Now I'm sharing my screen, and that should be moving. Please tell me that you can see that it's moving. Is it going forward?
Yes, yes. It's
yes.
It's moving.
Okay.
It's moving.
It's moving. Perfect.
Yeah.
So today my topic is, as I previously mentioned, the ultrasonography of the sacral nerve roots and the sacral plexus. And peripheral nerves are visualized with ultrasound in the last 2 decades regularly in orthopedics, neurologic examination. And peripheral nerves shows very nice longitudinal so-called bundle of straw characteristic ultrasonographic feature. And if we look this images, ultrasound images at the left side, you can see that where the white arrows are, these are the outer epineurium of the nerves. Above and under the nerves, you can see the muscles. They have similar, however, different ultrasonographic characteristic as the nerves. But the epineurium is hyperechogenic. Inside of the nerves, you can see some parallel lines. These are also epineuriums, and between the inner and the outer epineurium, there are these parallel hypoechogenic stripes, and these are the fascicles of the nerves. If we are looking at transverse plane, as in the right lower corner, you can see the so-called transverse feature of the nerves, peripheral nerves, and this is very similar like a honeycomb, so we call it as a honeycomb sign. If we are going forward, you have previously mentioned our article that we have worked out a technique how to visualize nerves of the sacral plexus during transvaginal ultrasonography. And this article was published last year in the Bite Journal. And in this study, we performed also laparoscopy, where we have dissected the retroperitoneum to see the branches of the sacral plexus, as you can see here at the right side, S1, S2, S3, S4. These are the main branches of the sacral plexus. And as you can see, there are also some other structures like the superior gluteal artery shown with AGS. And behind the nerves, you can see the piriformis muscle denoted with PM. And we performed an intraoperative scan during the laparoscopy. After dissection of the retroperitoneum and the nerves, we just filled and placed the califorceps on the S2 nerves. You can see that we filled with fluid the abdominal cavity that we could see during the intraoperative scan the structures in the retroperitoneum, and the key shows us the califorceps, which is a metal instrument and gives an acoustic shadow. And you can see the elliptic area, the circle shows us where the bundle of straw is, that the instrument was placed directly to the nerve. And how to perform this ultrasonography of the sacral plexus. It's mentioned in our article in 6 steps protocol. And you can see on the slide that we are showing the ultrasound image, also the intraoperative image where the transducer was placed with the asterisk in the middle. And on the right side, you can see the orientation of the transducer, and the triangle shows the direction of the ultrasound beam. So the first steps was an easy median sagittal view of the uterus. The transducer was placed in the anterior vaginal fornix, and the cervix, the uterine body, and the uterine cavity was shown in a sagittal plane, as the direction of the beam is shown with a dashed triangle. And then the second step shows that in the same place, the transducer, the asterisk, is at the same place in the anterior vaginal fornix. but at the height of the inner cervical orifice, we rotated the transducer in 90 degrees, so we could visualize the cervix in transversal plane. And in that image, in that plane, we can show in the ultrasonography image at the left side, the white asterisk shows the uterine vessels, uterine artery. And you can see the direction of the ultrasound beam with the continuous line triangle. When we have visualized the uterine vessels, then come the next steps, and we oriented our transducer. As you can see in the laparoscopic image, the black asterisk is just moved to the lateral vaginal fornix. So if you see the ultrasonographic image, the C denotes the cervix, and under the lateral parametrium behind them, we can see from the lateral vaginal fornix white, thicker hyperechoic stripes. And this is denoted in an ultrasonographic image with S, and this is the uterosacral ligament. And the uterosacral ligament will lead us to the lateral pelvic side wall. Uterosacral ligament is not every time attached to the sacrum. Most of the time it's attached to the obturator internus muscle or to the sacrospinal tuberous ligament, but this guides us to the pelvic side wall. And at the pelvic side wall, you can see at the third step, there is a muscle on the pelvic side wall, a hyperechoic structure, so SIN1, because this is the transverse section of the obturator internus muscle denoted with O. And lateral to the obturator internus muscle, you see the black arrow, and this is the sciatic bone. And if we just follow posteriorly the obturator internus muscle and sciatic bone, then it will end at the sciatic spine. And this is already the anterior border of the greater sciatic foramen. And this is the fourth step of the technique. It means we can see on the left side on the image, the uterosacral ligament, obturator internus muscle identified previously, and the sciatic spine. And the posterior border of the greater sciatic foramen is on the white hyperechoic thin line of the ala of the sacrum, denoted with AS. And between the two bony structures, we will see some other anatomical structures, like branches of the internal iliac, the anterior division of the internal iliac artery. This is shown with the white arrows. And behind the arrows, you will see with the black arrow, the bundle of straw. And these are the branches of the, or this is already the fused sacral plexus. And behind the nerves, you can see with P, the piriformis muscle. So these are the structures, vessels, nerves, and the piriformis muscle, which leaves leaves the pelvis through the greater sciatic foramen. So this is the place where we can find the sacral plexus. As standardized, we can tell that this is the sacral plexus until the obturator internus muscle, because when it leaves out from the pelvis, it will be the sciatic nerve. And we wanted to measure first with the transvaginal ultrasound the sacral plexus. And if we rotate the transducer 90 degrees, then we will get from the bundle of straw these other structures, this honeycomb structure. So this is the transverse plane of the sacral plexus. You can see still the obturator internus muscle. You can see with the white arrow the sciatic spine, and still you can see the anterior division of the internal iliac artery, at that part, the inferior gluteal artery. So this was the standardized plane where we measure the greatest diameter of the sacral plexus. If we follow the sacral plexus proximally and cranially to the sacral foramina, first we followed the anterior division denoted at the ultrasound image with A to the branching, where the internal iliac artery, denoted with the white asterisk, branches to A anterior and B posterior branches. And this is important because the posterior branch of the internal iliac artery gives us the main branch, the gluteal superior artery. And the gluteal superior artery is the only vessel which leaves the pelvis above the piriformis muscle through the suprapiriform hiatus. And this will verify you that previously you followed the anterior division, the gluteal artery, and you have seen the sacral plexus. And as you can see, the intraoperative laparoscopic photo, you can see as the asterisk shows the transducer in the lateral vaginal fornix, which followed the pelvic sidewall back to the greater sciatic foramen, is in direct contact with the S1 nerve, you see the black arrow, and also with the superior gluteal artery. So this was a proof that we are really in close contact with this nerve during the transvaginal ultrasonography. And the last step of our 6-step approach was to tracking the first sacral nerve root proximal just until to the anterior sacral foramen. And you can see with the black arrow at the ultrasound image that it's really the bundle of straw can be followed until the dashed circle until the anterior sacral foramina. At the left side, you see the white is the body of the sacrum, and the right side is seen a white line as the area of the sacrum. And even with color Doppler, you can see also with asterisk the sacral lateral artery. So this was the 6-step approach to see how to visualize healthy nerves of the sacral plexus with transvaginal ultrasound. And the results of our study was that more than 97% of the sacral plexuses could be identified during our study. And the visualization time was both sides 9 seconds. And the median diameter of the sacral plexuses at the right side was 15 and the left side 14.9 millimeter. So this is the median diameter of the healthy sacral plexus. I will show you next a little video. This is a brand new video we made this spring with Professor Daniela Fischerova and with 3 colleagues, Elena Gatti and Camilla Cucciasi from Italy and Zhu from Singapore. And this video is now a part of a new article which was accepted recently in the White Journal about the pelvic sidewall. And this part of the video shows us how to track the nerves during the scan. As I previously mentioned, this is the surveillance. This is the 2nd step of our technique. You can see the uterine vessels and how we follow the uterine vessels and the uterosacral ligament to the pelvic sidewall. Here is the hypoechoic area of the obturator internus muscle, and lateral to it there is the sciatic bone, the ischium. Now we are following posteriorly the muscle and the sciatic bone until the greater sciatic foramen. And you can see the end of the bone, the ischial spine. And you can see how the anterior division, the inferior gluteal artery, behind them, the nerves, and behind them, the piriformis muscles, leave through the greater sciatic foramen, directed to the gluteal region from the pelvis. So this is the 3rd and 4th step of our technique. You can see the sacral plexus. And if we are moving forward, we can see the piriformis muscle and rotating the transducer 90 degree. The honeycomb equitexture of the transverse section of the sacral plexus can be identified. And if we follow the sciatic nerve and the sacral plexus laterally, it is even possible with help of the color Doppler to see how from the inferior gluteal artery and from the anterior division of the internal iliac artery, also the pudendal artery branches, which will direct it to the ischial spine. And we can even see between the two structures the pudendal nerve. And if we follow the branches of the sacral plexus proximally and medially, we can use also color Doppler to find the branching of the internal iliac artery. We can follow the spinal nerve just to the sacral foramina, as you can see on the video. And we can see at the right side the ala of the sacrum, in the middle the body of the sacrum, and how the S1 nerve root goes out from the sacral foramina, and how at the opposite side the sacral lateral artery goes inside of the sacral channel. And if we use a good machine and we optimize ions and the image, we can see the bundle of straw structure clearly. So even another vessel, the obturator, another nerve, the obturator nerve can be followed on the pelvic side wall until the obturator canal. So this was our technique how to visualize the nerve. And what is the main reason we perform such ultrasound examination? Sure, this is the endometriosis, and we all know the burden of deep endometriosis in the world, and how many female patients are already women are affected by them. More than 190 million people in the reproductive age, females are affected. And this is one of the main causes for infertility and pain. But the problem is that globally, people wait on average 4 to 7 years for diagnosis. And we also know that there are a lot of phenotypes for endometriosis, even the superficial and the peritoneum, or the chocolate cyst in the ovaries, or adhesions causing a pouch of Douglas obliteration, or adenomyosis in the uterine wall. But deep endometriosis is the phenotype which causes the most severe complication for the patient. And in the last 8 years, we use the International Deep Endometriosis Analysis Group systematic approach to find these lesions. And if we are looking for the compartments described in this idea systematic approach, we will find the anterior compartment with the bladder and the ureter, and also the middle compartment, the uterus, ovaries, and the fallopian tubes. And the most deep endometriosis, however, comes in the posterior compartment with the rectovaginal septum, the vaginal fornices, the pouch of Douglas, uterosacral ligaments, and the rectum. And if we look in these areas, we can see that there are some other fields which remains, and this is the lateral compartment with the parametrium and the pelvic side wall. And parametrium can be a common site for deep endometriosis. You can see in the image the cervix in transverse view, and you can see between the uterosacral ligament and the cervix and the uterine vessels, there is a lesion, which is shown on the photo. And intraoperative image, you can see also near to the cervix, the lesion, which is now removed during the operation. And this is the postoperative site of the removed area. However, the parametrium was not clearly defined previously in the IDEA systematic consensus opinion. And therefore, last December in the White Journal, it was published an addendum to the IDEA consensus opinion, which already holds and describes the nerves, how to visualize them with ultrasonography. So this is already part of the IDEA approach. The most or the best classification for deep endometriosis is currently the #NCN classification. If we want to describe those lesions in the parametrium pelvic side wall, which are also affecting a nerve, we will find lesions in the so-called B compartment, in the posterior compartment. And this is the pelvic side wall sacroiliac ligament parametrium lesion, and we can describe with the F that the nerves are infiltrated. So if you don't know what is the compartment A, B, C, the #NCN classification, A is for the rectovaginal space, vagina and the retrocervical area. B is for the sacroiliac ligament, cardinal ligament, pelvic side wall, and C is for the rectum. And why is important the pelvic side wall and the parametrium? Because the parasympathetic visceral innervation of the pelvic organs reaching from this area, from the sacral plexus, and the S2, S3, S4 spinal nerves, anterior division of the spinal nerves, and from the sacral plexus are coming also some parasympathetic nerves from through the inferior hypogastric plexus to this area. If we are operating such patient, we have surgically 3 layers, and the most superficial to the abdominal cavity is the peritoneum, and under them the ureter. And the middle layer are the branches of the internal iliac vessels. And the most deep, the deepest layer is the sacral plexus, the obturator nerve, and the pelvic side wall muscles. And at the top of the pelvic cavity, the external iliac vessels. And now I will show you also a very useful tool described by the group of Professor George Candos Rao and Shannon Reid. And they thought that it's important if you want to, if you find an ovarian immobility at the lateral part of the ovary, so it can be a sign that for pelvic side, need for pelvic side wall surgery. So it's important to test the ovarian immobility not only for inferomedially to the uterosacral ligament or to the uterus or to the rectum, but it's also important to test the ovarian immobility laterally for the pelvic side wall. If we go further, we can see that deep endometriosis can affect really the nerves. This is a histologic image, 2 histologic images. You can see with the black arrow, these are nerves in the posterior parametrium, surrounded with some stroma, connective tissue, or even with striated muscle. And just in contact with the nerves, you can see some glands. The white arrow shows the endometrial glands. There are even some vessels with the black asterisk perfusing the glands. So deep endometriosis can really infiltrate nerves in the pelvic area. And what are the symptoms of the sacral plexus deep endometriosis? We can call it sacral radiculopathy or sacral plexopathy. It's a very commonly used radiculopathy. However, neurologically, the most correct is plexopathy, because the lesions are not in the sacral channel, but outside of the foramina, where already we call the nerves plexus, sacral plexus. And the main symptoms are chronic pelvic pain, dysesthesia, paresthesia, radiating to the ipsilateral lower limb or into the perineum even, and the corresponding dermatome. And there could be some weakness already in the ipsilateral lower extremity, depending on the respective sacral root. This is a patient in our hospital in the department on the corridor with affected sacral plexus from deep endometriosis. And you can see that she has also muscle weakness. This was just 1 day before her operation. And there are 2 types, according to Professor Horace Roman, of deep endometriosis lesions affecting the sacral plexus. Type 1 parametrial nodules are mostly medially, and they can associated very commonly with rectal endometriosis, ureter endometriosis, other visceral organs. However, more laterally, the type 2 parametrial nodules can affect the sciatic nerve and the obturator nerve, causing most radiating pain in the lower extremity or even motoric weakness. We don't know the prevalence of deep endometriosis affecting the pelvic nerves. We have a very nice systematic review, one from the group of Professor Engin Oral, published by Ahmed Kala, and he found in the literature 256 patients with sacral root sacral plexus endometriosis and more than 100 with isolated sciatic nerve outside of the pelvis at the gluteal region. And they found that the sacral plexus lesions are often concomitant with rectal, vaginal, ureteral, or bladder deep endometriosis lesions. And in late complication, urinary urgency and frequency were commonly observed in the sacral group. How to treat these patients? Laparoscopic neurolysis is written from colleagues. The first such type of operation was published in 2005, and two colleagues, Markus Possover and Professor Horace Roman, already published extensively about the operative techniques. But previously, it was thought that only MRI can visualize those lesions affecting the posterior pelvic wall and sacral plexus. You can see here a lesion near to the cervix in the parametrium, which is infiltrating not only the uterosacral ligament and the rectum with the yellow and blue arrows, but also the sacral plexus with the red circle. And please note that at that side, where the yellow star or asterisk shows the piriformis muscle, how symmetric is the piriformis muscle and thinner as the opposite side, as the innervation of the piriformis muscle is ruined because of the affection of the sacral plexus. Previously, in our department, in the neurologic department in our university, Professor Arányi made a nice study, a case series from patients with sciatic nerve endometriosis in the gluteal region. So it was a transgluteal ultrasonography. You can see the bundle of straw at the left side, and you can see as the deep endometriosis affecting the nerve, it's thicker and the bundle of straw structure is not clearly visible. So this was in 2016, the first article about transgluteal ultrasonography of the sciatic nerve endometriosis. And in our article last year in the White Journal, we have shown the first image how deep endometriosis, you can see the lesion with this yellow dashed line, how it infiltrates the sacral plexus. You can see with the black arrows showing the bundle of straw just anterior to the piriformis muscle and behind of the anterior division, the branches of the anterior division of the internal iliac vessels. So the parametrial lesion, as it infiltrates the nerves, was shown in our article. And you can see how the lesion was removed from the nerves. And now I show you a video how a deep endometriosis lesion can cause hydroureter at the pelvic sidewall. In the middle, you can see the dilated ureter. And now at the left side is the cervix, and this is the lesion, this hypoechoic nodule, which is in close contact with the hydroureter. And you can see the specular contour of the hypoechoic area, which is in close connection with the parallel white bundle of straw structures. So it's clearly visible that the nerves were infiltrated and the lesion caused also the hydroureter in that case. Just again, hydroureter, here is the lesion, the hypoechoic lesion. You can see it in the cervix, and the lesion is infiltrating also the parallel bundle of straw structure there. And please look for the intraoperative laparoscopic video clip. First, you can see the obliterated pouch of Douglas, and you can see how the dissection starts. And then when we go further, this is the peritoneum is opened. So this is the superficial layer for the pelvic side wall. Under the peritoneum, you can see under the suction, this is the hydroureter. So the lesion is infiltrating the parametrium and making a hydroureter. And under the ureter, you can see the clips, how the branches of the internal iliac, anterior division of the internal iliac artery, mostly internal iliac veins were clipped from the gluteal and the obturator region to find the nerves. And in the next seconds, it's shown how the neurolysis was performed, and the lesion very carefully, cautiously was removed from the S2 nerve. So this was a sacral neurolysis. Sometimes when you perform the sacral neurolysis, you can see that it is not only an adhesion, a scarring, but even when the operation is going on and the lesion is just removed, you can see as the endometrioma is opening from the lesion, and this chocolate fluid, this brownie fluid is also appears. It means that these lesions are really active deep endometriotic lesions, as you can see in the white circle. If we go further, sometimes lesion can even infiltrate intrinsic the nerves, as in that case. You will see now the little video clip, urinary bladder, vagina. This is the uterus and the ovary, a chocolate cyst, and this is a lesion on the pelvic side wall. And this hypoechoic lesion is very interesting because the nerve, this is an obturator nerve lesion, the nerve is going through the deep endometriotic lesion. And as you can see, the intraoperative laparoscopic video clip, this lesion is just attached very strong, very hard on the pelvic side wall. It's even not removable from medially. And then my colleagues tried to remove it laterally. The psoas muscle was just used for the dissection. And this is a very dangerous situation. Sometimes to remove this lesion, you can get huge volume bleeding from that area. So it's not without risk. Aims and methods was when we realized that we can see the lesions, the deep endometriotic lesions in this area affecting the sacral plexus, to describe how these lesions can be found in with ultrasonography. And we published an article this year in this topic about the clinical and ultrasound characteristics of those lesions affecting the sacral plexus. This article is just published in the July issue of the Wired Journal, so it's freeware, open access. You can find it. And together with Professor Gernot Hudelist and Professor Bokor, we have found in our retrospective study 27 patients with deep endometriosis lesions affecting the sacral plexus. And the symptoms were, in our study population, mostly dysesthesia and paresthesia in the ipsilateral lower extremity. Also, chronic pelvic pain was very common radiating in this lower extremity. But in some cases, we find not only pain in the pudendal region, but also motoric weakness, as I previously shown this patient. And in one cases, we also find a late complication as urinary incontinence. And the sonographic characteristic, what we found that those lesions affecting the sacral plexus are, have a huge diameter, mostly more than 2 centimeters. The median diameter was 3.5 centimeters. All of the lesions were solid lesions. Characteristically, the echogenicity was heterogenic, so mostly hypoechoic lesions with hyperechoganic areas. As you can see here at the left side, the upper image, there is this white spots inside the hypoechoic area. And those lesions affecting the sacral plexus gives very common, more than three-fourths of the lesions giving an acoustic shadow, an internal type 1. And if we use color Doppler, you can see that there is very scarce Doppler signs or even nothing. So color score 1 or 2 visible. And we also looked for if the lesions are only affecting extrinsic to nerves or going intrinsic also through the, and we found that about 30% of the lesions were intrinsic, but the 70% was extrinsic type. The sonographic features showed also that the lesions are mostly irregular, with irregular contour, and the contour is spiculated. And we also looked for ipsilateral ovarian mobility. About half of the cases, the ovary was attached to the pelvic sidewall. And we also looked for the sliding sign between rectum and uterus. And there was a negative sliding sign in 1/3 of the cases. However, site-specific tenderness was by all patients there. So we can conclude that we found those lesions with affecting deep endometriosis lesions affecting the sacral plexus are solid, non-uniform hypoechoic nodules with hyperechoic areas inside. They have an irregular spiculated contour. They show internal shadows, acoustic shadows, and they are mostly poorly vascularized. We also tried to see those lesions with sonoelastography, how thick, how stiff, how hard these lesions are, and we found that deep endometriosis lesions has an elevated stiffness and strain elastography, and it can be a good differential diagnostic tool for deep endometriosis lesions differing from benign retroperitoneal peripheral nerve sheath tumors, for example, from neurofibroma or schwannoma. If you are interested also how these peripheral nerve sheath tumors looks like with ultrasonography, we published also last year with Professor Daniela Fischerova an article in the Imaging and Gynecological Disease series about the peripheral benign retroperitoneal pelvic nerve sheath tumors, and you can find the ultrasound characteristic of those lesions also there. It's also open access article. So we can conclude at the end that transvaginal sonography is a reliable diagnostic tool for detection of deep endometriosis. And we found that in our center about in posterior pelvic compartment deep endometriosis was also together with sacral plexus involvement about between 1 and 2%, and associated deep endometriotic lesions in the rectum and in the urinary tract are frequent. I want to thank everybody for the attention, and also for my colleagues, Professor Bokor, Professor Udalis, and my fellow Professor István Manar, and also my young colleagues from the student scientific group to help us in these studies and also in the future. You can find me at X and Twitter, and also this is my email address if you have any help. And if you want to see me personally, or if you have time this autumn in Budapest, there will be nice meetings and congress. First of all, the ISOG World Congress in the middle of September, between 15th and 18th, and there will be also the European Endometriosis League course on ultrasound and endometriosis, which is a brand new series in the European endometriosis master classes. And in November, I will organize also a course in Budapest. So thank you for your attention. I stop the sharing, and if you have any question, I'm happy to answer it. Thank you.
Dr. Gaber, that was a fantastic presentation, really fantastic. It started off at the basics and really built up right till the end. So it was a phenomenal kind of work that you've done. Can I ask a couple of questions?
Sure, I'm happy to answer.
Now, does bowel preparation matter in if we are doing this study on OPD basis?
It's a very good question because previously I have also tried when I in 2016, 2017, it was a very interesting question if we should use before deep endometriosis scans bowel preparation or not. I also made half of the patient with bowel preparation and half of the patient without them. I think in the last 3-4 years, I never use bowel preparation, but these structures are in the most posterior part of the pelvis. However, our technique based that we are going to the pelvic side wall. We don't go directly behind to the rectum, but we
Right.
follow bony and muscle structures, which
Right.
are by every patient there. So I don't need to meet with the rectum. And I think
Right.
that's why you don't need to make a bowel preparation for the sacral plexus.
Right. Another question. Now, you have described an approach which goes from the lateral wall, medially downwards it goes, to locate the sacral plexus. At my center, we've been doing is also, apart from that works really nicely, but what we've been doing is go posteriorly to the identify the sacrum, go laterally to identify the anterior foramina, go little more laterally and then rotate your probe till it becomes parallel to the plexus and then locate the plexus. This is how we've been also trying to do at my center. Do you have any comments on this kind of an approach?
To tell the truth, we are also performed a study to see the sacral foramina and the sacral nerve roots. The question is, how can you identify which foramina and which nerve you have identified? Was it the first, the second,
Yes,
or the sacral one? And I
true.
think the most helpful tool are the vessels, because the gluteal
True.
superior vessel is stitching through the lumbosacral trunk and the S1 nerve, the
Yeah.
sacral plexus, and the inferior
True.
gluteal is going mostly, there could be some variations, but mostly between the second and the third spinal nerves.
True.
So
Yeah.
I think that could be helpful for your orientation if you are looking at that way.
True.
I
Yeah.
have one, just here, the same question here is, suppose the uterosacral is not visible, like in cases of large endometriomas, or sometimes you are not able to see the sacral, uterosacral ligament. Then can you use either the in posterior part of the ovary where you find the vessels as the landmark, or any other landmarks which you would say after uterosacral, or if uterosacral is not seen well?
I would recommend every time to find the obturator internus muscle and the sciatic bone, because these are very clear anatomical bony and muscle structures. And if you go from the cervix laterally, you will meet them in just 1-2 centimeter. And then if you have them and follow them posteriorly, this is the border of the greater sciatic foramen. You are there. I think the movement, what you shall not miss, if you have the patient in the position for the transvaginal scan, that if you have moved laterally to the pelvic side wall, you shall direct the transducer not only posteriorly but also inferiorly. I mean, you should elevate about 40-45 degree the outer end of the transducer, because then you are looking inside. So I wouldn't follow or search for the ovary, because in deep endometriotic patient, ovary can be stuck behind the uterus, and sometimes it is removed. Previously, there was an operation. So I would stay at the bony and muscle structure, obturator internus and sciatic bone. it will be there every time, 100%.
You also mentioned that move medially from the obturator internus and the bone, ischium bone, and then push it posteriorly. So,
Yeah,
what is this significance of this? Move medially and then downwards.
I mean, the most lateral part is the sciatic spine, and the nerve is coming from the middle, from the sacrum, and runs from posterior to anterior, from medial to lateral, and from superior to inferior. This is the advantage of the transvaginal scan, that you can follow obliquely the nerve. This is the main advantage to magnetic resonance imaging, to MRI, because then you will have the orthogonal plane. Here, if you follow proximally, medially, and posteriorly the nerve, it will lead you together with the anterior division of the internal iliac vessels to the sacral foramina.
And pain wise, one short question.
Yep.
We all know following the rectum, when you reach the uterosacral or the nodule, the bowel nodule, the patient winces a lot because of pain. What is the severity compared to bowel nodule, the severity of the pain that the patient experiences?
That's interesting. I think this is these are the same levels where the pain is coming in. I think if you touch the nerve, if you touch the lesion which affects the nerve, it will hurt. But I think there is not a separate pain, what you can tell that is stitching or burning or some cribbling or something like, because they are going to the same spinal segment. So I have no how to say, no feeling or no experience that there is something different from rectal nodule pain or affecting it. But there is only one difference what's important, that the obturator or the sacral plexus lesion, if you touch it, it will radiate to the lower extremity or to the pudendal area. This is a difference.
Yeah, I would say that the normal when you visualize the normal sacral plexus, patient has no discomfort or no pain or anything at all. Of course, if there is a pathology, it might be a different matter, as Dr. Gaber says. But normally, yeah. Now, one more question, Dr. Gaber. If the patient is a fat patient, or if the patient is a thin patient, would it make visualization any different? I mean, because of fat, is the other planes better outlined and you can see it more easily, or is it more difficult to see in thin patients? Is there any such experience that you have, or you have any comments to make on that?
In our first study, in the feasibility study, we looked for more than 20 parameters which can affect the visualization and the visualization time. And we found that age, BMI, previous operation was not an affecting factor. But we have found that deep endometriosis, because there is the pain during the examination, it makes the examination longer. So this is a factor which will influence the effectivity, but most probably the time they will need it. So mostly I am performing the scan in that manner that I leave this part at the end of the scan, because I don't want to abrupt I want to make a complete scan and let it. But because of the transvaginal feature of the scan, there is no problem if the patient has a high BMI.
Hello, I'm Dr.
Hello.
Madhavi. Am I audible there?
Yes.
Yeah, because the expert out here is there, I just wanted to show one case which was clinically suspected based on the clinical symptomatology of lower limb extremity. And the main clues to the pointer here was clinical history of lower limb dysesthesia up to the thigh, medially with tingling and numbness pointing to radiculopathy type of pain. So MRI was indicated because of non-clarity of the definition of the neural involvement on ultrasound, because we are not expert trained to root or to define the extent of the involvement of pelvic nerves. But we offered an MRI, and retrospectively we did an ultrasound correlation where upon clinical, the questions raised by Dr. Sandesh, whether the pain was more from rectal nodule or from the nerves, typically the difference between the dynamic assessment on a nerve and a rectal nodule is the pain of a radiculopathy, tingling and numbness was more apparent when the dynamic assessment was performed over the nodule in the lateral pelvic wall. And the traditional assessment of the pelvic side wall is best done in a clinical scenario by tracing the ureter. The ureter courses underneath the uterine vessels, defining the parametrium into medial half and lateral half. It is that lateral half which is the pelvic side wall, along which the obturator nerves and lumbar plexus course along the iliopsoas into the lower limb, whereas the sacral plexus is more medially and posteriorly. I think these were my findings when I did the scan, and any inputs from the expert out there.
So I think you are absolutely right. Those lesions which are affecting the sacral plexus, starting somewhere with the uterosacral ligament near to the parametrium, and these are in accordance with our findings that those lesions are huge. So if we have seen the hashtag NCI classification, we found that those lesions are minimum B2 or B3. So minimum 2, 3, 4, 5 centimeters big. And those lesions will reach from the uterosacral ligament, from the parametrium, the pelvic side wall. And the question is, what we can tell that those lesions are going to the sacral plexus? Will they infiltrate them? Will they be extrinsic lesions? Those can be carefully removed from the surface of the nerve, or even they are intrinsics going between the nerve fascicles. And there is a big help, I think, if we can visualize the lesions and tell the surgeons what they are. Sorry?
Like this nodule I was talking about in the lateral pelvic wall. Is it seen here?
Yes, I can see it.
Yeah, this is the pelvic side wall, and this nodule was so nondescript to comment confidently about the deep endometriotic nature in the setting of postoperative status and extensive adhesiolysis and otherwise unremarkable pelvis. Here, when you look into this, was that same protocol we use for evaluating the pelvic organ on a transcompartmental survey. And once you orient the probe transducer laterally, this is how, when we trace the ureter, this is the parametrium. This was the left ovary, which was streak morphology in the postoperative setting. And when we tried to extend our assessment to lateral pelvic wall, in view of our clinical symptoms of typical pelvic radiculopathy extending to medial aspect of thigh, this is the iliac vessel bifurcation. And we see this band of soft tissue separate from the ovary.
Yes.
This band, and this is the same band which was localized in the lateral pelvic wall. And so anatomically, it is anterolateral pelvic wall, this lesion. and it was separate from the ovary, this lesion.
Sorry, the question is now.
Now here, if you, like my question here is, until and unless you know the clinical neuropelviology assessment, isolated commenting on this nodule would have been difficult, because we needed to confirm this on MR correlation, and this was the nodule which was seen in the lateral pelvic wall.
Yeah.
This was the nodule with tiny foci of hemorrhagic components.
Yeah.
So my question here is, standard assessment of sacral plexus or iliac plexus without clinical implication, if it is not defined clinically, it is very difficult because of its non-specific nature and the localization in the pelvis along the lateral pelvic wall with not specific features. So do you think it is necessary for a proper clinical assessment before you sit down to assess this pelvic side wall?
I'm absolutely sure that the pelvic side wall should be assessed, because it's not only endometriosis, but one of the main reasons beside gynecologic tumors like cervical or endometrial cancer, that deep endometriosis, if it affects the pelvic side wall, it can affect, in that case, the ureter, or it can affect the sacral plexus both. And this is another operative difficulty level that if you compared to rectal endometriosis. And if I have seen your nice ultrasonographic, the MRI images and also the ultrasonography, there was a video clip at about 22, 23, 24th second. If we can go back to the transvaginal scan video clip, and that was the running time between about 22, 23, 24 seconds. Can you go back to the
Dr. Murthy, ultrasound video.
Ultrasound.
to the ultrasound
Okay.
video?
Yeah. I'll share.
Video at 22 seconds.
Yeah, sorry, just a question. So what do you think? Because we can see okay, this is the uterus. Now you are rotating, then I can see the
Here.
uterine vessel, you follow up. And this is
Yes.
the rectum behind the cervix, that's okay.
Correct. This is the ovary.
Yeah, this is the ovary, then that's my problem. Yeah, go further. We can see the ovary. Now we are waiting for the lesion.
This is the lesion.
Okay, yeah, stop it, please. Stop, please, the video. And what do you think? Which vessel was it lateral from this vessel, which is going in the pelvic side or behind
This
the
one is
ovary?
external iliac vessel.
Exactly. And that's the problem. If you see the white hyporechoic, if you run now the video, please run the video clip. Done it. Started. So if you see the external iliac vessel and you see just laterally to the external iliac vessel, you can see the continuous white line. And that means that you are not at the greater sciatic foramen, because you will see the body, you will see the bone. So you cannot see the sacral plexus, because the sacral plexus is going just going through the greater sciatic foramen. So you can see a nice pelvic side wall lesion, which affects the pelvic side wall, but it's still not the sacral plexus, which is infiltrated.
Yeah, because of its anterolateral location and not posteromedially. Exactly. And here the clincher was the clinical history of typical pain radiating up to thigh, not crossing beyond the knee joint up to ankle.
Yeah,
The patient had, and when the probe was pressed against this nodule, the patient complained of severe tingling and burning, which she experiences cyclically.
and which side of the thigh was
Left.
it?
Left
Left
No,
side,
anterior
but
posterior.
was it on the medial or on the lateral part of the femoral area?
It was on the medial aspect of the femoral area.
Exactly. So these are coming to the adductors. If you are so high, then these nerves is, as I previously have shown you in the laparoscopic video and also the ultrasonography, then the obturator is affected. However, big lesions can even reach, as Professor Horace Roman showed, the type 2 parametrial lesion, this anterolateral, can reach not only the sciatic but also the obturator one.
Like
and
here on this MRI, this
Yeah.
MRI, if you go from cranial to
Yeah.
caudal,
Yeah.
this is the iliac vein, common iliac vein. These are the arteries here.
Yes.
And the location of the lesion here is, this is the internal iliac, this is the external iliac artery. So the lesion is sitting over the bifurcation, just
Exactly.
proximal to the bifurcation.
Yes.
And it is not posterior and medial. Here would be
Exactly.
the anterior to piriformis, it would be the sacral plexus. Here it is
Yes.
pelvic side
The
wall, right?
obturator part, yeah. Yes.
So this is a deep endometriotic nodule along the pelvic side wall, impinging on the obturator nerve specifically or lumbar plexus. How do we report this?
Yeah. If the patient has exactly at that part where it's close to the adductor muscles, and if you can visualize the bundle of straw that I previously shown at the and this intrinsic lesion, then it can be that you can find the obturator. I have shown you previously. You can follow the obturator vessels, but then you should follow them. You should follow with ultrasonography the obturator vessel, and you will see as the nerve is coming to the.
Okay.
So
we have one question from
great
Suresh
diagnosis.
Naval.
Great
Okay,
diagnosis.
Gabor, there is one question for you.
Okay.
Have you tried to visualize the pelvic part of sciatic nerve along with sacral plexus?
I mean the sacral plexus, when it goes through the greater sciatic foramen, it will transform the next part of them is the biggest part of them is the sciatic nerve. So if we run the video, we have seen how the pudendal nerve was branched from the sacral plexus with the pudendal vessel, and the other part of the sacral plexus which goes laterally, this is already the sciatic nerve. If the question is if I can follow the sciatic nerve through the tunnel outside of the gluteal area, the problem is that the sciatic bone will give you an acoustic shadow, so you won't follow it very well, but therefore is the transgluteal approach, and then a transgluteal approach should be performed. So transvaginally, I follow the sacral plexus from the foramina to the greater sciatic foramen.
Is there any typical findings you have when the patient has muscle loss? Like suppose there is a loss in the piriformis muscle, or if you have the patient's gait is different. So do you find that these are the specific findings you will always find?
So radiating pain, dysesthesia, paresthesia, and the motoric weakness. So those patients are coming with sticks, right? And after the operation, the pain is very, very fast decreasing. However, the muscle weakness, then you need a good rehabilitation, and this is a difficult part of them.
Dr. Gaber, is it possible to have a sacral nodule in relation a nodule in relation to sacral plexus, and the patient has no complaints at all? asymptomatic? Is it possible?
I mean, if you touch it, as I mentioned, the site-specific tenderness, we had in our study, in our second study, by every patient pain. So direct touch gives pain. It's interesting because by rectal nodules, it's not 100%. In our study population, every patient has some complaints. Did somebody have such experience that patients were without complaint?
No,
I don't.
I'm
I
just
don't
saying because everybody is going to be new to this particular visualization of sacral plexus, and there could be errors in reporting also. So I mean, what if people start landing up with reports of a nodule and patient doesn't have any complaints? So I was just trying to uh,
Yes,
get an
I
idea as
see.
to whether that is possible at all. Yeah.
Yeah. I have no. We have no such cases. We are collecting our cases now prospectively, but I can tell you that all patients had some kind of complaints.
I mean, this will be so helpful if we have a gallery of images where everybody starts contributing to different types of images. Because in MRI, we can be very sure with white spots that this is blood and this is endometriosis. But specifically for ultrasound, it can be anything and everything which can be endometriosis. So I think with a large gallery like how you have in colposcopy, after looking at hundreds of images, we really start to pick up things. So same way, I think we should have one place, and this would be a boon for all of the surgeons who could at least after the surgery just sweep and see if anything is still left there, especially when they are doing posterior parametrium or the lateral parametrial excisions, and is there something beyond which I am missing now. So that itself would be really helpful to complete our surgery, and that would really help us to actually relieve pain for these patients.
I think you're putting ideas in Dr. Vimi Bindra's head now.
No, I was about to mention about the intraperitoneal ultrasound we are already using. So if any residual lesions are there, so we have intraperitoneal ultrasound and we can always check that. How is your experience with intraperitoneal ultrasound, Gabor?
Sorry, just repeat the question.
Intraperitoneal ultrasound, intraoperative ultrasound with a BK medical probe, which we use, the laparoscopic or the robotic probe we have.
Didn't use I haven't used until yet intra operative robotic ultrasonography with intraperitoneal. I hope I will have the chance for that.
So yeah, so many centers have acquired that, and it's also a good tool to look for the residual lesions where we can go in with the barbell lesions when we are doing shaving or discoid excision, and also may be helpful for sacral plexus as well, but haven't tried it yet.
Yeah, I think this is very important that I mean this complete dissection of the pouch of Douglas and also complete dissection of the lateral parametrium when it's needed. It's performed during the operation, and if for the surgeon is helpful to use this intraoperative ultrasound, I think then it should be used, because what we can do every time when there is such type of lesion diagnosed in the ultrasound unit, I'm going to the operation theater, and if I'm not operating a patient, I'm there and looking, because the feedback is extremely important in that cases, as you mentioned, not only for the surgeon, because the information that look at that, you should remove those lesions, but also verifying the sonologist or the diagnostic colleague that it was a good diagnosis, or maybe not complete, because from every cases we learn something. It's very important for both of us.
Fantastic presentation, Gabor, and I was spellbound by your expertise when in EEL you showed Katerina was doing the ultrasound, Dr. Sandesh, and she was doing a live ultrasound. He was standing in the audience. He just told her to move the probe and he showed us everything on the screen. He was not doing ultrasound.
Okay,
he
great.
just told Katerina, you move your probe, and he started showing us piriform. This is the sacral plexus, and we were just spellbound in the audience.
So it's very reproducible and standardized.
Yeah.
I mean, Katerina is an expert, but she was also happy to do it, and it was a very good situation. I hope if you can come to Budapest sometime, maybe to the ISO Congress, or maybe to some of the EL course, or maybe sometimes I can visit India. We have never been
Yes,
there.
2026, I would invite you to India.
Absolutely happy to go there and happy to meet you personally.
You know, I was about to say that Dr. Vimi Bindra is going to be inviting Dr. Zabo, and before I said it, I think she said it. So we'll be really looking forward to this kind of a conference.
No, before we end, I would really like to one more time see this new video which you have prepared now. Can you just go back to that video, please?
Absolutely.
It was awesome. It was really a fantastic video.
Okay. Just a second. Okay, I'm sharing my screen. Can you see my slide?
Yes, we can.
So I'm starting with the video. You can see the anatomical sketch. You can see now the cervix in transverse plane, uterine vessels, and the parametria. Now I'm sliding, and just look, I made a slide movement, just followed laterally to the vaginal cervix, and look at that, the obturator internus muscle and the sciatic bone is there. Now I'm just following the two structures posteriorly, and I'm already looking the ischial spine and structures going through the greater sciatic foramen. Anteriorly the vessel, so use the color Doppler. Behind them the nerves, and posteriorly the piriformis muscle. And the area of the sacrum is the posterior border of the greater sciatic foramen. So that behind the ischial spine, you will see the sacral plexus. So this is the piriformis muscle. And then you can see as I rotated the transducer, here is the honeycomb, and here we can see the transverse plane of the sacral plexus. And if we focus to this area, then we can use color Doppler, looking for the gluteal inferior artery. And then there is a part of the nerve and the little vessel which is going to the sciatic spine. And this is the pudendal nerve. So the branching is there, and the internal pudendal vessels goes with that. And as I mentioned previously, here was just a second, I go back. Again, sorry. So the question was, why cannot follow the sacral plexus or the sciatic nerve? Because here is the ischial bone. and this gives us an acoustic shadow. Okay, so that's why you won't follow it. Use the transgluteal. And then the next part of the area, how I follow the video clip, how I follow the nerves cranially, the sacral plexus cranially, together with the inferior gluteal vessels until the sacral foramina. And how the nerves is just entering the pelvis from the sacral foramina. And then you can see the bundle of straw there. It will be made with this yellow coloring in just a couple of seconds. The bundle of straw. Okay.
Excellent.
Okay. And just a second, I stop the video and show you what previously we have spoken. Previously, we have seen when the colleague asked the external iliac vessel, yeah? And the obturator now. So the previous lesion is somewhere here, and the in the ureter is coming also at that area. So the previous question about the lesion, which was anterolaterally, because it was here. Can you see my moving finger?
Yes.
Yeah. So the previous lesion was somewhere here, and the sacral plexus lesions are here, posteromedially, as he correctly stated. As she correctly stated. Good.
Jimmy.
That was
Thank
a
you.
fantastic session,
Fantastic.
Dr. Sabo. Fantastic. Just
Thank you
there's no
again
other
for your
word for
time.
it. Yeah.
Thank you so much, Zabo, for taking out time and educating all of us on this technique.
Thank you again, and I wish
Yeah.
you a nice evening,
Thank you.
everybody.
Yeah.
Thank you. Thank you so much.
Yeah. Thank you. Good night.
Goodbye. Good night.
Yeah.